All right, welcome everybody. We'll get started with some introductions of the Midwest Tribal ECHO team. Dr. Robbie?
So obviously it's okay to eat during lunch. Hi, I'm Froehle Robbie. I'm a family practice physician and veterinary medicine physician here in NACC. I've been here since 2011 and been working with the MAT program since 2016. Welcome.
And thank you. And Nikki?
I'm Nikki Jardine. I'm the infectious disease nurse at NACC, and I have been here since 2017 and worked with the harm reduction team as well.
Thank you. And I'm Lindsay Kincooney. I'm the harm reduction coordinator here at NACC. And we'll move on to some announcements. I'm going to share my screen. So welcome again, everybody. We're the Midwest Tribal ECHO Opioid Use Disorder Education and Treatment Series. We have George Froehle today joining us talking about adult gender medicine and primary care. So a little bit about NACC. We were established in 2003. We're an FQHC in the heart of the South Minneapolis urban indigenous community right on Franklin Avenue. Below is a list of all of the services that we provide and our website. This is a list of current open positions at NACC. If you go to our website down at the bottom, you can read more about these positions. Some session guidelines, please, no protected health information. If you're able to turn your camera on, we love to see your faces. And then if you could let me know who you are in the chat, so your name, title, organization, and email, I can get resources out to you. And then some announcements. So next ECHO is coming up. We have May 15th. Kumi Smith will be talking to us about racial disparities and fatal overdose in Minnesota. And then June 5th, we'll have an ECHO as well, but to be determined. This is a list of other ECHOs that cover similar topics. Hennepin Healthcare, Indian Country ECHO, and Stratus Health. If you'd like more information, just let me know. And then we do offer continuing education credit. So if in order to get the credit, you just have to fill out the post-evaluation survey, which I will put in the chat today, as well as email out to everybody. And then case presentations, my email is at the bottom there. If you do have one to provide for us for an upcoming ECHO, we definitely welcome. They make for a great discussion. And I think with that, I will hand it over to our speaker. Welcome, George.
Thank you. I will get this set up here. Okay. And folks can see the presentation? Excellent. Great. So hi, everyone. George Froehle, a PA. I'm doing primary HIV care at Hennepin Health at the Positive Care Center. And I also do a little bit of work at the Aliveness Project now as well. Before this position, I was in St. Cloud, Minnesota, doing a gender program with Johnny Steffens. And before that, I was at Mount Sinai in New York City at the Institute for Transgender Medicine and Surgery. So today, I'm going to give us a quick overview about gender medicine. This, of course, won't be an all-encompassing talk because that's hard to do in this time frame. If you get a copy of the slides, you're also going to see that when the talk ends, there'll be some additional slides after that about gender-affirming surgeries that we won't be covering today, but I thought that might be of interest for some folks. So if you want to spend some time looking at those slides after the talk, you're more than welcome to do that. These are our objectives for today, and we're going to kind of dive in. Because there is a substantial amount of material, I'm going to ask that you ask questions as we go, but I'll answer them at the end. But I want you to ask them as we go so that you don't forget them as the presentation is going on. Okay, so thanks so much. So I know gender has become more and more common in our culture and that lots of people are familiar with this concept, but I just want to make sure everyone's on the same playing field. So to just do some basic definitions, when we're talking about gender, that's different than sexual orientation, right? So sexual orientation is who you love. Gender identity is how you define your gender. And gender is different from biologic sex, where biologic sex is what you're assigned at birth, but gender is really your identity, how you feel. and how you express to the world and how other people see you. So those are different things. Sometimes when I give this talk, people get a little bit confused about the word cisgender. So I just want to define that now as we go through the talk. So cisgender refers to someone who identifies with the gender they were assigned at birth. So if I was assigned male at birth and I still identify as male, that would make me cisgender, right? So as I use that term throughout the talk, I just want you to be aware of that. Pronouns. So we talk a lot about pronouns. The three most common pronouns that are used are he, him, she, her, they, them, but there are others, but this is the three most common. Using people's pronouns is really important for a variety of reasons, but there are some studies that show that it can decrease symptoms of depression, reduce thoughts of suicide and attempts of suicide, especially in adolescence. But it also shows that when we use someone's pronouns that we're being culturally competent and we're listening to folks and meeting them where they're at. In the past, we used to write in chart notes, patient's preferred pronouns are, or patient's preferred name is. We no longer use that word preferred. It's not really necessary. We just say patient's pronouns are and patient's name is, right? We've kind of gotten away from using that preferred language. In asking someone's pronouns, there's lots of different ways you can do it. I sometimes say, hello, my name is George. I use he, him pronouns. How would you like me to address you today? Sometimes I'll just say, and what pronouns do you use? I think people in the culture have gotten a little bit more used to being asked about pronouns. So, just making sure that we have that. In your EHR, you're probably able to enter someone's pronouns now, and that's really helpful for folks to have that in the chart so that the next person who sees them is able to quickly reference that. Now, it will happen that somebody will misgender a patient at some point, whether that's you, the front desk, your medical assistant, anyone, pharmacist. It can happen along many ways. When that happens, we have research that shows that folks prefer that whoever did the misgendering apologize, but then move on to the topic that the patient is there for that day. So you can simply say like, oh my gosh, I'm so sorry. I know she, her, I'm very apologetic. That won't happen again. What brings you in today? Right. But we know that when people go on and on about apologizing, that's actually a little bit more uncomfortable than just apologizing and moving on. And then making sure that we have a notation in the chart again around someone's gender identity can help prevent misgendering in the future. So currently, the definition for the diagnosis for gender is gender dysphoria. In the future, this will switch to gender incongruence. And in some EHRs, you can actually select that now. This is going to move gender dysphoria out of the mental health disorders category and more into the sexual health category, the same kind of historic way that homosexuality was removed from a mental health disorder. So that'll be good. But when we're talking about providing care to folks who are gender diverse, we have to have this diagnosis in order to move forward with treatment. So I know this is a little bit of a wordy slide, but this is the actual text on how we diagnose someone. So I'm just going to go through it real quick with us. So in adolescents and adults, gender dysphoria diagnosis involves a difference between one's experienced and expressed gender and assigned gender and significant distress or problems functioning. It lasts for at least 6 months and is shown by at least 2 of the following. So it doesn't need to be all of these, but 2 of these below items, okay? So a marked incongruence between one's experienced expressed gender and primary and or secondary sex characteristics, a strong desire to be rid of one's primary and or secondary sex characteristics, a strong desire for the primary and or secondary sex characteristics of the other gender, a strong desire to be of the other gender, a strong desire to be treated as the other gender, and a strong conviction that one has typical feelings and reactions of the other gender. And you can hear in this definition, even the definition of gender dysphoria is rather binary. It's like the other gender, right? Where gender is more of a spectrum. And so the hope is that this will be adjusted a little bit so that it's a little bit more matching our time about what gender identity is for folks. But when we're making this definition, folks have to have had 2 of these symptoms for at least 6 months. Now, we know that treating people for their gender dysphoria or gender incongruence can be beneficial for the patient. We know that it helps with depression, anxiety. We know that in women with trans women with HIV, that when we treat their gender dysphoria, we actually see better viral suppression rates. And we know that by treating gender dysphoria, we decrease cost to the system, which is always, someone's concern, cost. So these next few slides are going to give you references for you to look at if you are going to do gender medicine in the future, right? So the first one is this one, which is WPATH, the World Professional Association of Transgender Health. They've released their Standards of Care 8. So this isn't our typical guidelines. This isn't going to tell you how to do hormone therapy, but it's going to tell you the diagnostic criteria and how really the clinic should be set up for these things. So it's more of the standards of care. So WPATH is a really valuable tool. It's what all of us use, especially when we're, arguing with insurance companies about surgical clearance and all of that. The Endocrine Society has treatment guidelines. This is more of like a position paper than it is classic guidelines, but they have them. There is a slight bias towards endocrinology as a specialty versus primary care. So this one I don't utilize too much. It's not too different from the other guidelines, but I just want you to know that it's available. The University of California, San Francisco, they really have like the gold standard of guidelines when it comes to gender medicine. This is their table of contents. It's got all sorts of links to any sort of questions, concerns that might come up when you're treating someone who's gender diverse. This is the go-to resource guide that most of us use all the time. You're going to see lots of information from this in this talk today, but this is where it comes from. I would definitely like put this on your bookmark on your online EHR or website, and you'll use it often. There's this additional one called Transline, and Transline is sort of my favorite, just to put out my bias. This is a collaboration of all the who's who of LGBTQ community centers who've come together to create these guidelines. And we'll utilize these throughout the talk as well, just so you can get a little bit more familiar with them. I think these are a little bit more approachable and easy to use during the busy clinic day. So again, this is our diagnosis for gender dysphoria, right? People meeting 2 of these criteria for at least 6 months. So that's how we define gender dysphoria, and we get a diagnosis. But then WPATH lays out what the criteria is for hormones and who can be sort of offered hormones. So to go over that, it's gender incongruence that's marked and sustained, meets diagnostic criteria for gender incongruence prior to gender-affirming hormone treatment in regions where a diagnosis is necessary to access healthcare. This is the World Professional Association of Transgender Medicine, so that's why it's sort of like that. Demonstrate capacity to consent for the specific gender-affirming hormone treatment. So, and noting that in the chart that the patient is able to consent, or if they have somebody who consents for them, that person has provided consent. Other possible causes of apparent gender incongruence have been identified and excluded. Mental health and physical conditions that could negatively impact the outcome of treatment have been assessed, with risks and benefits discussed. And then to understand the effect of gender-affirming hormone treatment on reproduction and exploring alternative options. So part of this is getting at, when somebody comes in and is talking about this, just assessing like, is this person kind of like in a good place to be starting on hormones? Is this person maybe having a manic episode and sort of parsing that out? Like, is this just a good time to consent and move forward is what this is about, and making sure other medical conditions are reasonably well controlled. When I talk about initiating hormones with patients, we sit down and we discuss the goals of therapy. Like, what do you want to see out of this? What could hormones bring to your life that you're hoping would improve things? Like, what do you want to see through this hormone management? And that can be really important because it can help set goals, but it can also set expectations. And we want to discuss the potential side effects of hormones, and we want to discuss potential effects on fertility and discuss what to do if a patient's gender identity changes, right? So I always wanted to let patients know that gender can be fluid, gender can change over time. If anything changes in the future, you're in a safe space. We can talk about that, and we can talk about what to do about it. So just know that that's always on the table should you want to talk about it more. Fertility and hormones. So this is a little bit of a complex topic just because we don't fully know the effects of fertility when people are on gender-affirming hormones. We don't typically test people for fertility like before we start them on hormones. We don't know if someone could become pregnant or help someone else become pregnant before we start on hormones. But we just want to have the conversation that it's possible that being on hormones could reduce someone's ability to have biologic children in the future. And if that's really important to them, then either sperm banking or egg harvesting should be done beforehand. Sperm banking is a little bit more accessible. It's a less invasive procedure. The costs involved with it are lower. Egg harvesting or egg preservation is much more expensive and is a bit more of a procedure, and can be a bit more of a barrier for folks. But it's very important, especially in this sort of political climate, that this discussion be had and that it be documented in chart that this conversation was had. And a patient should do the fertility preservation before starting on hormones if biologic children is important to them. All right, let's talk about how we actually do this. So let's talk about masculinizing hormone therapy. So it's important to know that patients can switch between modalities. So the current modalities are either an injection or people can do topical gels. There is a patch, which I don't utilize much in my practice. I know a lot of people get rashes from the patch. If anyone else here uses the testosterone patch and really likes it for their patients, please let me know in the comments. But it's not one that I typically utilize. The shots are done weekly if we're using testosterone cypionate or testosterone enanthate. And the difference between those two is the seed oil that it's mixed in, but you can see that the dosing across this chart is still the same. And this chart is from UCSF. So UCSF breaks it down that you can do an initial low dose when you start, or you can do an initial typical dose. So that's up to you and the patient about whether or not they want to start on like a lower dose or a typical dose. I'll sometimes use like a low dose and maybe somebody who's non-binary and they're just sort of thinking about exploring this a bit more, where somebody who is like, I'm a man and I want to be, I want a beard as soon as possible kind of a thing, then I'll start at the initial topical dose or the initial typical dose. So patients can choose whether they want injectable or topical. The injections are subcutaneous most of the time. You can do them intramuscularly as well. They hurt a little bit, but they're not too bad. But some patients, the idea of a needle is just a little bit too much, and so they may want to do the topical gel. The topical gel is applied each morning to the upper arms and shoulders. It can also be applied to the thighs if people prefer. This is done every morning, and so for some people, this is just a little bit much of a breakup of their morning routine, and they may try it for a couple weeks, and then sometimes they'll message being like, hey, I want to be on the shots. But some people do the gel all the way through, and that's totally cool. And again, you can see the initial dosing here, and then how we ramp up. Now in the shot, in the comment area, it says that it's a 2-week shot, but we actually encourage people to do it weekly. The reason we do it weekly is when people do it every 2 weeks, they get this high peak of testosterone that slowly comes down over 2 weeks. And it's that peak that can cause a bit more acne and a bit more hair loss. And so we like to dose it weekly so that we get less of those effects. So weekly is typically how it's done now. There is a third shot on the testosterone induncanate shot. This is for 10 weeks. So this is also known as a VEED. That's the brand name for it. And this can be a really great option for folks. It's a one size fits all. There's no real dose changing, but it's for 10 weeks. And this is typically done at a urology department because they typically buy and bill the VEED. So this is the medications that are available when we're doing masculinizing therapy. In terms of labs, when somebody starts on testosterone therapy, we like to get a hemoglobin and hematocrit. And then UCSF recommends that people come back in 3 months. And at that 3-month time, we get a total testosterone and a hemoglobin and a hematocrit. And then every 3 months for the first year, those 2 labs. After the first year, you can shift to every 6 months, or if somebody's extremely stable on their dosing and doing well, you can see them annually. There are some other labs in here with some asterisks, like the sex hormone binding globulin and the albumin. These are to get if something's off, like you're prescribing a typical amount of testosterone, but their testosterone labs don't look right, or they're not masculinizing in a way that you would expect. That's when you would start to look at those. And that might be when you email me and ask me like what's going on here, and we can talk through the case. But when we're looking at total testosterone, our goal range for testosterone levels, and this is the total testosterone, is about 300 to 1,000. And that follows Fenway's guidelines, the Endocrine Society, and UCSF's guidelines. So that's what we're looking for, is about 300 to 1,000. If somebody's on the injectable medicine, if they're doing a shot weekly, we need to ask them what day of the week was their shot. How many days ago did you do the injection? Because as this chart shows, when somebody does an injection, they have a peak level of testosterone, and then over the course of the week, it starts to be used up by the body, and so it goes down. So if you're checking somebody's testosterone on their 4th day of their shot, and it's at, 800, well, that's probably a little bit high, even though it's within the reference range, because it's towards the end of the shot cycle. So we would more so expect it to be maybe 500 at this time, right, or 400. So we just need to utilize that when we're interpreting this data. It would be lovely if everybody came in, on 3.5 days after their shots, we could get a mid-level cycle, but people's lives are a little bit more chaotic than that, and that's hard to organize. So I just always ask, what day was your shot? And then kind of look at it with that thought process. If somebody's low and we want to go up in their dose, then I typically go up by like 0.1, 0.1, 0.5, like 0.15, depending on how low they are. We'll make those adjustments and then have them come back in a month or 3 months to recheck and see if they're at this goal range of 300 to 1,000. This is a patient's favorite slide. This is like when will changes happen? And so this is an exciting thing for a lot of patients to look at. It's very important to go over the irreversible side effects of testosterone therapy. So the irreversible effects are scalp hair loss, a deepened voice, facial and body hair growth, and clitoral or genital enlargement, right? So if those things happen, that's irreversible. These are the reversible and the variable changes that take place. But most often when people start on testosterone, the first things that happen are that their skin may get a little bit more oily and acne may start to develop. Sometimes after 3 months, I'll see a little bit of hair growth on the upper lip. Those are typically the things that begin first. One of the things that patients ask about is when will they stop having monthly bleeding? Monthly bleeding can be quite dysphoric for some patients, and typically that should be in 2 to 6 months, but that's 2 to 6 months after they're in that 300 to 1,000 range. So if they're having a low testosterone level and we check it and they're still having monthly bleeding, that kind of makes sense. We need to have them in that 3 to 1,000 range for that to happen. It's a good idea to let patients know that even though they might be in that therapeutic range, there are about 15% of patients who will still have breakthrough bleeding during the course of their treatment. They may have spotting here or there. And so giving them a heads up that might happen, it doesn't mean that anything's wrong, can be very helpful, just sort of getting ahead of it. But if it does happen, a patient should come in and we should check their testosterone level to make sure they're in the goal range or make dose adjustments. And if they are in the goal range, then we should work up that bleeding. So some side effects with testosterone. This is basically the most common one in my clinical experience, which is secondary polycythemia. So what this means is that the blood can get a little bit thick, right? So the hematocrit might go up. If this happens, it's like the heart pumping molasses versus water, and so that can add a little bit of extra strain on the cardiovascular system. So we want to monitor that. This typically happens on injectable medicine. We don't typically see this on the topical. So if somebody does have thickened blood, we can always talk about reducing their dose, or we could talk about switching them to the topical therapy. Either one of those decisions. You can also do therapeutic phlebotomy for people if needed, but that can be quite a challenge to arrange. So it's often easier to do dose adjustments or switch to a topical regimen for a while. Moving on to feminizing therapy. So feminizing therapy is a little bit more complex in that there's more medications to use than there is with masculinizing therapy. So again, we will use estradiol. So estradiol comes either as an oral option, or it can be a transdermal as in a patch, or it can be an injectable. All 3 routes are totally okay to try for most patients, and it's okay for someone to switch between them again. So again, this is UCSF using the initial low, the maximum dosing. Now, here they make a comment that if it's greater than 2 milligrams per day, they recommend dividing it into BID dosing. So I'll typically go to 4 milligrams once a day, and then after 4 milligrams, we'll start putting it into BID dosing. I think those of you who work with patients know that BID dosing is a very big ask. It can be really difficult to get people to take pills twice a day. So that's a limitation here with the pills. But we don't want people taking all 8 milligrams once a day. It's just a little extra estrogen all at once, which could lead to potential side effects. So we break it up at that point. The patch is a really great option for folks who can tolerate it. The patch gets applied one patch twice a week. So about 3 days or 4 days through the week, they'll pull the patch off, put another one on. Some patients will wear 2 patches or 3 patches, just depending on their labs. But this can be a great option for people. They just shower with the patch on. There's also the injectables. This is estradiol valerate or estradiol cypionate. Again, it's the oil. That's sort of a change. But there are different doses with these injectables, so it's not a one-for-one switch. Transline, that resource we talked about in the talk, they have a conversion chart there that's really helpful. So this is also a once-a-week shot. It can be subcutaneous or intramuscular. And this is really what a lot of our patients come in asking for is the injectable. A lot of people will tell folks that the injectable develops changes more quickly. That may or may not be true, but that may often be a patient's preference to be on the injectable. We also will utilize T blockers or testosterone blockers. Most commonly, this is going to be spironolactone. I think a lot of people are probably familiar with this as a potassium-sparing diuretic, whose second side effect besides potassium imbalance is gynecomastia, so breast growth in people assigned male at birth. So that's kind of one of the benefits of it, right? It's going to block testosterone's effects in the periphery of the body, and it'll also stop testosterone production a little bit at the testes. And how this is beneficial, besides the blocking, is that if we produce less testosterone, we maybe don't need to give as much estrogen to counteract testosterone's effects, so the doses can be a little bit lower. And so that's the goal. Again, there's this initial low and then initial and maximal. I typically will go 100 milligrams once a day is typically my preferred route. I just think BID is hard for patients. So I normally will keep it at 100 milligrams a day. There's this little nugget of information buried in the UCSF guidelines, which I have written out here, which says that if chest growth is an important thing for your patient, maybe hold off on starting the T blocker for 3 months after you've started the estrogen, because there may be a potential benefit for breast growth. It's theoretical, it's not science, it's not for sure. So there's a lot of providers who will just start estrogen and a T blocker all at once. That's totally cool. But if it's really important to the patient, I'll often wait on the T blocking until I see them back. Again, patient's favorite slide. What are the changes? When is this going to happen for me? Kind of a thing. The important thing to note here is the only irreversible change from feminizing therapy is chest growth. Everything else is either reversible or variable. And the first things that most patients will experience is a reduction in oily skin, a reduction in acne. Some people will start to feel some chest tenderness as their chest starts to grow. Typically, that growth will start within 3 to 6 months of starting on hormones, but again, that's having them in the therapeutic range, which we'll talk about in the next slide. And it can take up to 3 years before maximal chest growth. And this is a good discussion to have with patients about what their expectations are for their body changes. And if somebody has expectations that they want a certain size growth, it's important to talk about the genetics of their family, like what do the cisgender women in your family look like? Maybe that's more in line with where things will get for you. But if that's not up to what you were hoping for, we do have other interventions like surgery that could be available should you want that, right? And then we'll see some decrease in body hair growth and loss of scalp hair, but it does not get rid of facial hair or body hair in any way. It just decreases the growth and thins it out a bit. Unfortunately, estrogen does not raise the voice the same way testosterone deepens it. And so if somebody wants to do any sort of voice feminization, that's typically done with speech therapy, and a patient can be referred for that. Progesterone is another option. It is a little bit more of a controversial option. There are some clinics that just don't use progesterone. I'm not one of those providers. I'm okay with patients trying it. Again, this is from UCSF saying basically there may not be any evidence that progesterone really causes increased feminization, but there's no evidence that it's super harmful. So UCSF kind of says it's a shared decision making. I'll typically do a 6-month trial period with the patient And if they feel like it's been beneficial for them, then I'll keep it going. If they don't, then we'll stop it because less medicine is kind of the better. But what most people think is that progesterone causes weight gain. And when we do weight gain in an estrogenized environment, that weight tends to be more in the chest and in the hips and the thighs. And so it can sometimes help with feminizing body shape. And then some people feel like it really evens out their moods a little bit. But these are the two types of progesterone to use. If you are going to use it, you don't want to use anything else, but other than these two options here. And we don't check labs for this. We just sort of treat to patient experience. So these are the labs for feminizing therapy. The goal range here is typically about 100 to 200. I know there are some clinics that'll go up to 270 or so. I generally keep it below 300 and more so around the 200 range. When somebody has baseline labs, if we're starting the T blocker with spironolactone, we'll get the BMP, right? Because we're going to be checking for potassium basically. But if we're not starting the Spiro, we could hold off till their next follow-up visit. The labs for this one, though, going forward are going to be a BMP, and then we're going to get an estradiol, and we're going to get a total testosterone. So with masculinizing therapy, we just got the total testosterone and the CBC. With feminizing therapy, we're going to get a BMP, estradiol, and total testosterone. And again, these other labs down below are if things maybe aren't going as expected, or if somebody has signs of a prolactinoma. So signs of prolactinoma are a reduction in peripheral vision and also any sort of discharge at the nipple. If that were to happen, we would want to get a prolactin level, and I'll show you that in the next slide. Again, UCSF recommends that patients come in every 3 months for the first year, and then they can come in every 6 months or 12 months, depending on that. Because I work at the Positive Care Center where most of my patients have HIV infection, it actually works out nicely with hormones because when patients come in for their HIV labs, we just do their hormone labs too, and it's all just kind of like seamless for me, which is a nice thing because they match up in terms of follow-up schedule. So again, the prolactinoma. So when somebody has any symptoms or concerns about a prolactinoma, we'll go ahead and get the prolactin level. This is from this text is from UCSF, but these ranges are from Transline. And so if you do have someone and you get those labs, you can reference Transline to see like what the next steps are. I've been doing gender medicine since 2008, and I've been concerned about this twice. So it's not super common, but it is something to have in the back of your mind and know where to reference should this come up for you. Okay. The other side effect that people think about when they think about feminizing therapy is blood clots or thrombosis. They've been studying this more and more about the effects of estrogen that we use for gender medicine on development of thrombosis. And it looks like it's actually less likely than we kind of originally thought, but it is something to have in the back of the mind. And patients who are on, especially the pill version of estrogen, should be thinking about what a DVT looks like so that they know that happened. They should go to the emergency room or the urgent care. We also think about this the same way we think about birth control. So age, someone's smoking history, and their weight all play into factors of increased potential for thrombosis. These complicated algorithms are here from UCSF, but they're just here because I wanted to show that if somebody has a family history of a coagulative disorder, or if they themselves have had a blood clot in the past, it doesn't mean that they can't be on estrogen therapy in the future. It means that they would need to be probably on the patch version of it, right? Because the patch skips that first pass metabolism that can increase someone's risk for blood clotting. And this is important for folks to know because I do have patients who come to me after they've been to the emergency room with a blood clot because they had just had like their gallbladder removed or something, and they had a blood clot, and then they went to the emergency room, and instead of them being told it was because of the surgery, they tell them it's because you're on estrogen and you can't be on estrogen anymore. And then I get these like frantic phone calls being like, what in the world? It's just a very scary thing to tell someone that they can't be on their hormones anymore, especially if it's like not accurate. So I just like to hammer home that point. But they should be evaluated before starting, and if they are on oral, that should be stopped, and folks should be moved to patches. All right, so this is sort of when we prescribe the injectable, these are the equipment that we provide, right? So testosterone comes in a 1 ml vial, and estradiol comes in a 5 ml vial. So patients have access to more than their weekly dosing, right? And so we typically will prescribe a 1 ml syringe with an 18 gauge needle. And then a 22 or a 23 gauge needle if we're going intramuscularly, or a 25 gauge if we're doing it subcutaneous. Now, there's no reason to do intramuscular over subcutaneous. It's whatever the patient preference is. And in my experience, that's mostly subcutaneous because it's a smaller, shorter needle. But we'll use a thick needle to draw up the oil and then the thin needle to inject. Sometimes when a patient comes in and their hormone level is high, I'll think it's maybe because they've been doing a little bit too much hormone. But sometimes what I find out is that it's because the pharmacy gave them a 3 ml syringe instead of a 1 ml syringe, and it was difficult for them to actually pull back their proper dosing, because it's really hard if you're doing like 0.2 to get that accurate on a 3 ml syringe. So we really work with the pharmacies to try to give them the proper size syringe. In doing gender medicine, oftentimes patients will come in saying, hey, I read about this online, or I saw this on a TikTok video, and I want to get your thoughts on like if I can do this too, right? And sometimes it's super rational, super cool things, but sometimes it's things a little bit out of the box. And the way that I approach that is I'll typically say something like, okay, like I'm hearing that maybe something's not going right for you with the hormones, or there's maybe something else you're hoping would happen. Like, what is that? Like, what are you hoping to get out of that? Let's talk about it and see what we can do, and kind of work with them on it. But I do stick to the guidelines on treatment therapy. But I do want to hear patients out about what's going on and maybe satisfaction, non-satisfaction. I don't like to just tell patients, oh, that's not what we do. We don't do that here. Move on. You know, I try to meet them where they're at and see if we can find an alternative solution within guidelines. So patient education materials, like if I'm starting someone on a patch or subcutaneous injections, this organization called Folks Health has these really great resources that were made by gender diverse people for gender diverse people. So I'll send them a link to a specific article or print it out and give it to them. But I find this to be a really helpful resource for folks, and they have an article on almost everything. So it's also a great place to go if a patient asks you a question that you're not sure about. You can check out UCSF's guidelines, but you can also go to Folks Health's library. And there's additional learning. The National LGBTQIA Plus Health Education Center is like the best place. Their library of free webinars and CME is outstanding. So I would recommend checking that out. And then WPATH themselves also has educational options available. Trans Lifeline is, I think, a number every clinic that has gender diverse people in it should have on hand. This is a crisis and suicide hotline number that's run by gender diverse people for gender diverse people. So a really important resource. This is also a place that people can go to for micro grants if they want to get like a chest binder or anything like that. They can sometimes get that for free through Transline. And then the Aliveness Project has a social support group called Tea Time, which is really popular, and patients can connect there if they want to meet like-minded folks. All right, do we have time for a case study? Yeah, okay. So I like this because I think we're just gonna put all this information we just went over, we're gonna like put it together and make it a little bit more user-friendly. So let's do it. All right, so Vanessa is a 40-year-old person who presents to clinic to establish care with you, right? Here are her vitals. Blood pressure looks okay. Weight is about 200 pounds and her height is about 5'8". Depending on your clinic and how you work, you may have like somebody fill out a form before they come back with their sexual and gender history, but otherwise you may need to ask that. So you're going to collect that. How do you identify your gender if you do? What pronouns do you use? What are the genders of your sex partners? And how do you identify your sexual orientation if you do? And then alcohol and drug screening questions per usual. So Vanessa states she identifies as female and uses she, her pronouns. Her sex partners are mostly cis males, and she meets most of them on Tinder. She doesn't really drink, but she smokes cannabis occasionally. She doesn't consume nicotine in any form, including vaping, and she's not allergic to any medications. She denies any significant past medical history, including HIV infection. She has no significant family medical history, and she has a full-time job and feels financially stable. She states she's here today because she would like to start on hormones. So Vanessa states she wanted to start on hormones for many years, but was concerned how her grandmother would feel. Her grandma's now passed away, and she'd like to start. She already presents to work in female clothing and is out to most of her friends and family. Her employer has been supportive. Again, she doesn't smoke, no significant medical history, and she'd like to start on hormones today and maybe have breast augmentation surgery in the future. Her last HIV test was 3 months ago and she was HIV negative. Her condom use is frequent, but not always, and she's heard about a pill to prevent HIV and she'd like to know more about that. And she's otherwise asymptomatic for STIs today, and no one told her they may have given her an STI, but she's open for screening today. So does this patient meet the diagnosis for gender dysphoria using the DSM-5, right, criteria? So again, this has to have lasted for more than 6 months, and she must have had 2 of these criteria. So looking at this, she said that this has been going on for years. She's felt this way for years. She's already presenting to work in female clothing. So she meets that 6-month sort of threshold, right? And then she meets basically every other criteria in my clinical judgment. But again, this is clinical judgment, and you might disagree. But in my mind, she meets these and qualifies for the diagnosis of gender dysphoria. So what do we need to consider? So from her history, we know in vitals, we know she's 40 years old, and she's a little bit on the heavier side. While a blood clot is generally unlikely, we'd like to really decrease this risk, right? Because a blood clot, if it were to happen, is a life-threatening event. So we really just want to be clear about that. So which estrogen option is safest for a blood clot? Well, you'll remember George said something was safest, but I can't remember exactly what it was. But George said, go to Transline. He always said, Transline, Transline, Transline. So you pull up the Transline, you're looking at your different estrogen options on the left. You look at the notes section and you see here patches, preferred method for those with increased risk of DVT, PE, or CVD, right? So there we go. That's the one, right? And so we can talk about patch options. And what I like about Transline is it's 9 pages. It's just 9 pages. Like UCSF is a whole table of contents, and this is just very user friendly. I have this stacked to my desk with a pen, and I look at it every single day, right? But so this is nice because it's got the starting usual dose, your typical max dose, the frequency. It's got pros and cons listed, so really nice little clinical nuggets just right at your fingertips. So again, for Vanessa's case, we're thinking, okay, we're over the age of 35, a little bit on the heavier side. Maybe patches is the way to start. So we're going to show every patient's favorite slide about changes and when we can expect those. We're going to go over the irreversible changes that can occur. We're also going to talk about fertility preservation if that's important to her. And then we're going to discuss that when we draw labs, our goal is for your E level to be like 100 to 200, maybe a little bit higher, but around that. Because sometimes patients will go home and talk to their friends and say, hey, I'm on 0.4 mLs of this drug. Why are you only on 0.2? And then the patient will come to you and say, hey, why are you holding out on me? And it's like, no, your E level is what we're looking at. And so you might be a faster metabolizer or a slower metabolizer. It's not about your dose, it's about your E level, right? And then that can be really reassuring. So I typically see patients back 1 month after starting hormones. UCSF says 3 months, but I like to see them back 1 month because in my experience, most patients have been waiting a really long time to start on hormones and they want to get to that therapeutic level as quickly as possible. And so I want to see them in a month and just up dose if we need to, right? But then I'll see them back every 3 months for the first year. And then after that, every 6 months. And again, for me, that's kind of easy because it correlates with their HIV follow-up visits. And we'll discuss the need to be on hormones for 1 year before breast augmentation. That's kind of variable now with the new standards of care 8. But we're not going to talk about surgeries today, but I just want to say one thing quick, a little bypass, is that WPATH has their own set of guidelines around, their standards of care about who can have surgeries when, but an insurance company will have their own set of guidelines and standards of care, and which may very well not align with WPATH's. And so that can be a little bit frustrating. But just know that sometimes you're following WPATH to the letter, but insurance companies just write with a different pen. So we have to play with those rules. So back to Vanessa. So we discussed be on hormones for a while before breast augmentation. And then I'm going to send through my chart or whatever EHR you have, a link to how to apply patches, right? So it talks about how to prepare the skin for the patches and what to do if one slips off, right? So I'll send that information along as well. So then, Vanessa asked about PrEP. I'm sure you've all have had lectures on PrEP before, so I don't want to bore you to death. But we would talk about the options for her. So for her, she would be eligible for Truvada or Descovy or the injectable PrEP cabotegravir. whichever one she would sort of prefer. We're also going to let her know that her estrogen won't impact her daily prep or her injectable prep. There is some misinformation online that being on hormones can impact both prep and HIV medicine, and that's not really accurate. So we'll just beat that to the race. We'll just say, nope, this, right up front, this isn't going to be a problem. The only time that we need to have a shared decision around PrEP and estrogen therapy is if a patient's going to do PrEP on demand. So on demand meaning the 211 version where you take it around a sexual event. In the clinical trials, trans women didn't acquire HIV any differently than daily, but when they looked at the PK data, looking at how much of this drug do we have in our blood per day, there is a little evidence that estrogen can reduce the amount in the blood, but that doesn't seem to be significant when it comes to actually acquiring HIV. But because we don't have a really robust trial with trans women, it's important to just sort of have that shared decision making and let them know that there is this reduction in blood levels, but it doesn't seem to be clinically significant, but that is there. So maybe you'd prefer daily, or maybe you'd prefer the injectable, whichever one, we'd be happy to do that with. If on this visit you wanted to start both hormones and PrEP, the labs sort of coincide, right? So you're going to get a BMP and then all the other PrEP labs. And then you can start both at the same time and see this patient back in 3 months or 1 month, and then 3 months after that. All right, that's sort of the chat, but I'm happy to take any questions, or if you're a hormone prescriber yourself or provider in any way, and you have additional nuggets or thoughts, please feel free to chime in.
Yeah, thank you. I think Ren put something in the chat for a resource. Would like to share NRHC's new guide for navigating access to gender-affirming hormone therapy as a resource as well. And then there's a link there in the chat for folks. Thank you, Ren. Do you want to stop sharing maybe, and then we can see
Ooh.
faces and
Yes,
have
thank
any
you so
questions?
much.
No, thank you.
There we go. Good, thank you.
There was a question in the chat earlier about the figure that you were showing about levels of testosterone as a function of the time post-injection, I think. I think you were saying in days post-injection, but the figure was saying weeks. So we just wanted to clarify.
Yeah, thank you so much. So that graph is for the long-acting injectable testosterone, the AAHIVS, and so it was in weeks, but the same concept applies for the weekly shot, but in days, right?
Okay.
So you want to think about it in days when you're doing the weekly shot. I just couldn't find another infographic that laid it out in that way, so I apologize for that, not letting you know.
Gotcha, thank you.
Mm-hmm. Cool. Well, I just want to give an open invite to folks that if you are, doing hormone therapy or supporting folks on hormone therapy or who may want it, and if you have questions or concerns and you want to reach out to me, you can feel free to email me, and I'm always happy to be a local resource for folks who may want some extra support.
We do have a question, actually, if
Yep.
you had talked about sometimes with multi-use vials or the when it has more in it than someone needs, so then they're going to have extra. And so wondering if you then, I guess, what
Sharing.
Right, advice about harm reduction around potentially sharing,
Or using more than dose of a single dose.
Yeah, so obviously we talk to patients about not sharing, but we know the real world is that people will often share, right? And especially when it comes, so with the testosterone therapy, there's normally about 2 doses in a vial, but with the 5 mLs of estradiol, it could be like a lot of extra doses in there. So we encourage not to share. We encourage keeping it at room temp. We encourage using an alcohol swab to wipe off the stopper if we're using it. And of course, never using the same sharps and syringe, right? That's the best thing we can do around harm reduction. And I think letting folks know that more isn't always better when it comes to estrogen therapy, that like the magic sweet spot for feminization without side effect is that like 100 to 200-ish range. That's why that's the range. Doing more doesn't necessarily mean you'll have more feminization. It might just mean you have more complications. So I hope that's helpful.
I was curious. Yes, I think that's important. I was curious as to, since we have had an uptick in the amount of people requesting syringes for hormones, just like clearly people are sharing their lives.
Mm-hmm. Yeah. And in the olden days, before the Affordable Care Act, when hormones weren't approved by insurance companies, people would buy them online in various different places, and we often didn't know how much people were using or where they were even getting it from. It was kind of the Wild West before the Affordable Care Act. So often if people do have health insurance, they can get hormones covered, but it's not, yeah, it's still complicated.
And there's a couple, or I guess a few more questions. Bobby asked, very informative and comprehensive training. Could you touch briefly on how to best support a client who is contemplating this decision?
Yeah, so when somebody's contemplating it, if somebody hasn't already made up their mind, which is normally who I see, they normally are like, I've made up my mind on what I want to do. But if somebody's thinking about it, what I'll typically do is refer them to a therapist who has special training in gender medicine. And I'm spoiled because I have a therapist here in my office who has special training, so that's really helpful for me. But Rainbow Health has therapists as well, who can meet with folks through telemedicine to talk about it. But I normally tell patients that this journey is really theirs, that I'm not the accelerator and I'm not the brake. I'm the seatbelt to just make sure that this drive goes successfully for folks, right? And that I'm just here to help guide. And so you don't need to make a decision today at all. You can think about it, take time. Here's Transline. Go look at their resources here's Folks Health. Go look at their patient education materials, take a read, see what you think. Follow some people on TikTok, get some community support, go to tea time, meet with some people, see what their experiences have been, and come back to me when you're ready. Yeah.
And then another question from Andrea, are providers in gender medicine usually primary care clinicians, or do psychiatrists or other specialists also do this work?
Yeah, so this would be a great fight with the Endocrine Society. So it depends where you work. So my personal bias as a primary care provider is that this is a primary care realm. We're talking about 2 to 3 medications that we prescribe to cisgender people for multiple things already. So to me, it's something that has an ongoing shared relationship throughout time, and it offers us the opportunity to provide prevention and other primary care supports if people are on hormones. So I view it as primary care. Psychiatrists and so endocrinologists are another specialist who do this, as do some urologists and some gynecologists or OBGYNs also provide this. Like Planned Parenthood will often provide hormones for folks as well. And then in terms of psychiatrists are often there to help support patients, but probably don't prescribe the medicines themselves. But psychiatrists play an important role, especially when people are trying to seek surgical interventions. People will need at least 1 letter from a psychiatrist in order to get surgical interventions. So it's important to have a partnership or someone you can refer to for that.
Thank you. And then some other just resources shared. So Ren did offer that she can give tips about harm reduction practices when sharing vials. And then Dr. Conniff, hi Jamie, put into the chat Past Remembered project that offers free virtual LGBTQ specialized mental health care for Indigenous folks. And there's a link in the chat as well.
Awesome. Thank you. I didn't know about paths, so I'm stealing that one from you, Dr. Conniff. Thank you.
All right, well, I think we have to wrap up. Thank you so much, George. This has been excellent. And thank you everyone for joining us and your participation. Have a great day.
Thank you.
Thank you.
you.